Hello, y'all. So for this health coach PSA, I'm not doing a health coach PSA. This is my third installment of the history of healthcare. And I think moving forward, I'm just going to do at the very last week of each month, I'm going to do a history of healthcare installment. So if you have any topics that you want me to cover for next week's Health Coach PSA, be sure to drop a comment in the comment section, and I'll be sure to make a note of that to put that in the lineup. But for today, we are going to be discussing the history of medical coding and specifically how upcoding and facility fees led to a $3,400 needle stick. So this is kind of interesting. So I'm kind of excited to talk about this today. So Dr. Randy Richards, who is a surgeon in Tennessee, didn't think much about the bills his patients received until 2014 when he got picked with a needle in the operating room. And so, like doing your needle stuff. All right. So back in the 1980s, before the HIV era, people mainly wore gloves just to remain sterile, keep the OR clean, and to prevent transmission of germs and stuff. But by the 1990s, all hospitals had strict codes for reporting such incidents, partly for safety concerns and partly for liability reasons, just to make sure that the person didn't already have HIV or hepatitis, and so they won't get sued. But today in the hospital, a needle stick requires an immediate blood test, just in case they need to start medication. But anywho, after Dr. Richards got this needle prick, he reported to the ER to keep up with standard protocol. He did his part. But some months later, he was shocked to find that his medical bill was as follows. So he was charged $1,137 for the ER doctor services, $48 just for the nurse to put an oxygen meter on his skin, and $2,198 for hospital services. So this brief blood draw had been coded as a level 5 visit. And that is the most intensive, which according to the guidelines for Center of Medicare and Medicaid Services, or CMS, that requires a detailed history, extensive management of lab results, and examination of multiple body systems. And he even said, he was like, what was written down really bears little relation to what was done. And he was like, the net charges are just disassociated from reality. And all I needed was a simple blood draw. Like, what the crap? Like, what is all this? Okay, what is this? So anyway, he even tried to reason with the ER doctors to get them to change the code or to change the price on the bills. But his doctors, they stood by the billing. They're like, no, that's right. Like, we did right. There's nothing wrong with the bill. Just pay it. It's just $3,400 for a needle prick. And he was fine. So don't worry, I'm gonna give you the tea on that. So around 2000, the hospital became worried that some of their doctors were not seeing enough patients or bringing in enough revenue. So there was this hospital that decided that it will no longer pay their doctors regular fixed salaries. And instead, they would be compensated in proportion to the relative value units, or RVUs, of the care that they dispensed. So, in layman's terms, RVUs are a measure of productivity, and they're used to determine medical billing. So, generalists, general practitioners, they are assigned RVUs primarily according to the complexity of their exams and treatment plans, and they're coded on a scale of 1 to 5. So a simple level 2 can yield as much as $60, level 3, $120, level 4, $210, so on and so forth. So Once they started implementing these codings and once the doctors stopped getting fixed salaries, what would start to happen is that lots of pink eyes and simple things would be billed as level fours, which may not sound as much, but it can add up. And so this was being done because of a financial incentive, and colleagues who were coding expansively could make twice as much than other doctors. So they could make around $300,000 annually instead of, say, $170,000 annually, depending on how they coded their procedures or their patients' bills. And so, because many prestigious medical centers have all their medical staff on a salary, they thought that their physicians and surgeons didn't really have an incentive to upcode or perform unneeded tests and procedures. But many of these well-known health systems tie those salaries to physicians' RVUs, or sometimes they would even offer productivity bonuses. So, and this even includes Harvard affiliated Partners Healthcare, Henry Ford Health Systems, Duke Health, Baylor Scott and White Health. They would offer productivity bonuses if they would get coded, if their patients got coded higher. So just another reason to bring in revenue to the hospital, so to speak. And so there were a small number of hospitals that would even go as far as to deduct money from a doctor's salary if his or her RVUs were too low. I mean, if a lot of people are healthy and they don't need to code for level 4 or 5s and they get 1s or 2s, then they would just end up getting penalized for that, which is kind of messed up. But that I just say that all to say that the bonuses can motivate doctors just like they do bond traders or anybody in the sales field that gets bonuses. So I know what you're thinking, why didn't anybody try to stop this? Haha. Insurers, particularly Medicare, they try to prevent upcoding by spot audits of the charts. But hospitals, they're like, don't worry, I got you. Let me help you out with this. And so they would help doctors with the coding. And so one doctor said that it's like a candy store. All you have to do is check the right boxes. And so you get what you want depending on what you put. And so they had software that went as far as telling them that they only had to check 2 more boxes if they wanted to code for level 4. And so they're like, oh, wait, you're almost there. If you check 2 more boxes, you can get level 4 instead of level 2. And so anything as simple as a questionnaire that's filled out by the patient, that can be labeled as a health needs assessment, which is a billable item. So just filling out a questionnaire can be billed, depending on how they code it. And so injecting a patient's bum knee with steroids can be coded as a surgery that can cost up to $1,200. That's a little crazy if you ask me, but that's not even it. The coding problem grew even as far as to where it made no sense at all. So if needle sticks and eye infections were level 5, then what the heck would you code a client or a patient who got into a car accident and crushed his chest, or heart attacks? A level 20? It's ridiculous. So anywho, Center for Public Integrity, or CPI, investigative series, they found a huge increase. This was in 2012. The Center for Public Integrity in 2012, they found a huge increase between 2001 and 2008. Remember, this started in 2000s. So between 2001 and 2008, they saw an increase in Medicare billing for level 4 and 5 visits in amongst emergency room patients. They were actually sent home. They weren't even staying overnight. They were just level 4 and 5 emergency room patients that would sit home. And this increase went from about a quarter of the patients to almost half. And so meanwhile, the proportion of level 2 visits, they decreased to about half. They decreased about half to just 15%. And so about more than 500 out of the 2,400 hospitals in the database, they were billed the 2 most expensive codes for more than 60% of patients. So about 20% of the hospitals billed more than 60% of their patients codes 4 or 5 or higher. All right, so Dr. Donald Berwick, who is a former Medicare administrator, he told the CPI, the Center for Public Integrity, that he believed that most doctors, they weren't breaking the law, but they were just learning how to play the game. Because, they're no longer salary and they see an opportunity to make as much money as possible and impose, like, if you had an opportunity to make $170,000 and shifted to be able to make $300,000 annually just by checking off some more boxes, I'm pretty sure a lot of Americans would do that, especially considering all the fraud that went on during the pandemic with these stimmies. So don't be too surprised. But anywho, do you remember Dr. Richards, who the needle prick, and that facility fee that cost $2,198? Yeah, don't forget about that. And I'm about to get into that in a little bit, or right now. So these facility fees, they didn't exist 20 years ago. And they wouldn't have happened back then because the facility fees were a logical outgrowth of a period of rapid scientific progress in medicine. And so a lot of treatments that were usually inpatient procedures that would require overnight stays are now able to be done in one day, so the patient can be in and out. So what is that? Outpatient settings. And so with the improvement in anesthesia, pain medicine, minimally invasive surgery, and biopsy techniques, that meant that many procedures and operations could be safely performed without overnight stay. And that is not good because hospitals had traditionally charged a day rate for inpatients. And it makes sense that they would create a facility fee in lieu of the decline of inpatient care. So insurers, including Medicare, they had largely accepted this. They were just like, okay, that's cool. And so they just let it, like, it is what it is. By the turn of the century, didn't nobody blink an eye at it. And so, of course, abuse and fraud eventually crept in because of this, since facility fees provided easy ways to manipulate the system for gain. So there's a lot of leeway in the pricing of something as vague as 2 hours of endoscopy suite, because some fees are billed in 15-minute increments. So they can just bill it and price it for whatever. And so facility fees provided a great incentive to stop performing any and all procedures in doctor's offices, and instead they would use a surgery center or a hospital outpatient department. And so the wonderful Dr. Ronald Anderson, who was a Pennsylvania rheumatologist, he could be able to inject a bursa, little pocket in your joints, specifically like your knee. He could inject painkillers in your bursa for $80, but a patient can go to an orthopedist in a surgery center with ultrasound guidance and be billed almost $5,000. But you know, who cares, because the insurance paid for most of it. So whatever. That's why I got insurance. That's why I'm at my miserable job, because my insurance gonna pay for my body. The cycle continues. But anywho, facility fees are a unique construct of American healthcare and its business model. So hospitals in Europe don't have this, nor do other types of businesses in the US. So when you buy a watch, a car, even groceries, you pay just a single price for the goods. You don't walk into a local Walgreens and get a separate charge for the rent, utilities, and costs of the refrigeration units. You just pay for the item. And that's not how it works in the healthcare system. And it all happens because the hospitals wanted more profit, and so they started incentivizing doctors to bill higher. And so, like I said, this is why people stay with jobs that probably make them miserable or stress them out, because they're like, well, I don't have anywhere to go because I have a good job with benefits. And so if I lose my job, I won't have the insurance. I know when I was up in San Francisco, there was a guy who worked the building. He was like Mr. Fix-It. He did everything. But his wife had cancer, and so he should have been retired like 5-6 years ago, but he keeps working just for the insurance. And so I just say this all to say, if you want to save money, you would be best working on your health yourself and doing the preventative maintenance, such as diet, exercise, working on your mental health, working on minimizing toxins, and doing all those things necessary to prevent you from even needing the hospital. And yeah, so I hope this was very informative, and stay healthy out there, you guys. Happy Thursday.